Thanks, Javier. A slightly overly generous introduction, but I'll take it. First, thanks to the anesthesia department for letting me do this today. It's always a pleasure to see old friends and think about how our life together has been. So what I'm going to do today is talk about the founding and early days of critical care at Stanford, talk about some major developments in the field and its evolution as a discipline, and I'll show a couple of interesting papers that I think transformed it. And then I'm going to talk about the considerable challenges of it as a discipline. And then I'll make some final comments about how lucky we all are to be able to do something that matters to a lot of people. So the origins of critical care are kind of obscure. You can pick many areas. During the Crimean War, Florence Nightingale had a critical care protocol in hospitalized soldiers that reduced the mortality from infection. Some people cite that. The first 3-bed neurosurgical ICU at Hopkins was in 1926, but the one that most people cite is the first med-surg ICU, which was in 1953. Set up in Denmark, actually, because of a polio epidemic, where they had 200 medical students hand ventilating patients. But as a discipline in the United States, it really is in 1958 when there was the first multidisciplinary ICU in Baltimore City hospitals. A famous anesthesiologist, Peter Safar, shown in the picture, cutting the ribbon. And in 1986, the American Board of Medical Specialties approved certification. They called it Special Competency in Critical Care for Anesthesia, Medicine, Pediatrics, and Surgery. In my own opinion, that was a mistake. They should have made it a single specialty, maybe for adults and for pediatrics, in the way that emergency medicine crossed a bunch of disciplines. And forevermore, there's been debate and tension between various specialties about who gets access to the ICU, who's controlling it, and how we interrelate. So the founding of critical care, I think of as being almost entirely by Mike Rosenthal sitting here. He moved from Bethesda's National Naval Medical Center to Stanford on September 1st, 1975 to start Stanford's unit. Certification didn't really even exist then. When I came here in 1983, there was no board, but in 1986, it was opened up, as I've said, for all specialties. Mike was number 3 to achieve it in anesthesia. And then in the subsequent years, he was very involved in anesthesia critical care certification, even the chair of the committee. And for 22 years, he was the medical director. And he pioneered the idea of multidisciplinary critical care at Stanford. I think Mike won't believe this, but I think all of us felt like we were slightly in his shadow for many years. But, you know, I was okay with it. I'm sure he doesn't believe that. But he cast a long shadow. And the other thing that I was grateful to Mike about was that he really pushed the idea that the trainees were part of the most important part of being an attending in the ICU. And I think that's persisted for almost 50 years. There are other original intensivists. On the top is Rob Sladen, who is a Summa grad from South Africa, from Cape Town. He went on to Duke and became division head at Columbia, retired in 2017. Tom Feely, who became the division head at MD Anderson in critical care and is now at Harvard Business School talking about healthcare policy. And of course, we still have Ron and Fred here. So Ron, obviously chair for many years. Many of you may not know that he dallied in medicine before he became an anesthesiologist, and so did Fred. And Fred's been very active in international work and has tons of interesting slides and pictures from everywhere in the world. And we've had a lot of trainees, 353, Fred, who keeps track of it, tells me. I've just offered a few of the ones that we didn't keep here because we tended to keep our best trainees. And, you know, on the top, we have two people from Canada, Rob Fowler and Deb Cook, who have both been heads of the Canadian Critical Care Trials Group, which is probably the most important trials group over the years of any. Avery Tung was the University of Chicago, Rich Prelip, who was chair at Minnesota, Lorene Hill, who was chair at Emory, went to WashU, and then is now at Presby in New York. Sarah Krieger, who's down in UCLA, where Liz Turner went. There's tons of people I could talk about, and I've, you know, omitted many that are super important, not only as a source of pride for us, but are really important in critical care throughout the country. And it underlines what I said about Mike, which is the trainees are really probably our most important legacy, because they extend the influence and the science and the community. So now I'm going to talk some about the major developments and what I see as defining trends in critical care over the last 40 years or so that I've been involved in it. So in the 70s to the 90s, it was largely a physiology discipline in which we tried to figure out how we could manipulate physiology to support people who are critically ill. This is a CT from 1999 of somebody that had ARDS, and it showed the usual features, which is, you know, left lower lobe collapse, right lower lobe partial collapse, inflation of the upper lobes. We spent a lot of time trying to figure out how to ventilate people. Most of it originally was barred from anesthesia in the OR. And gradually we began to understand that it's difficult to ventilate injured lungs because the non-dependent regions are more inflated than the dependent regions. So early work actually in Milan and in Spain brought into relief issues around how we were ventilating people. And there were sort of two kinds of concerns. The first was that in dependent zones, the lung was partially or fully collapsed. And the question was, how much pressure should we use to inflate it? And so this is a dependent zone that with every tidal volume opens up partially, but then collapses. So maybe not adequate for keeping the lung inflated. And as you increase the PEEP, you get more constant inflation, but still some collapse. And then when you increase the PEEP even more, you get more inflation, and it seems more satisfactory. But then the problem is in the non-dependent areas of the lung, you get overinflation. And this was brought into relief really in the 90s, but it really came home to roost in a paper in the New England Journal in the year 2000, which showed that the survival of people that had lower lung volumes, lower tidal volumes, that's the solid black line, was better than the survival of people that had lower tidal volumes. And so this to me was an example of our beginning to understand in physiology that things that we thought were conventionally true were not always true. So our recognition that the usual methods of mechanical ventilation really induced a lot of lung injury. And it ushered in even more an era of intense investigation about how do we inflate the lung. That continues over the years. So, you know, interest in transpulmonary pressure, the difference between alveolar pressure and pleural pressure, PEEP levels, what's the best PEEP? There's a whole giant literature on what's the best PEEP, including lots of controlled trials, and it really isn't settled. And it's probably needs to be individualized for each patient. And we don't have a great method of doing that. Recruitment maneuvers, like should they be single? Should they be multiple? How long should they last? Proning, which of course COVID brought into relief. There's a lot of interest recently in diaphragm strength. So this is all an example of the physiologic phase of critical care in which we're dealing with gross macro systems and trying to understand how to be better at it. Now, we also did a lot of hemodynamic monitoring for many, many years. And in the 70s and 80s, we put in hundreds, actually thousands of Swan-Ganz catheters. And this was a guide for us to volume and also allowed us to, as we thought, control pressures better to optimize cardiac output. So these guys, Swan-Ganz, devised the Swan-Ganz catheter in 1970, initially for MI treatment. Kanu Chatterjee at UCSF spread the gospel of it in cardiology in the New England Journal. And then then in 1985, a person in the pulmonary division at Stanford, who was a physiologist, who we all thought was slightly out of touch, wrote this article in Annals of Internal Medicine called The Cult of the Swan-Ganz Catheter, Overuse and Abuse of Pulmonary Flow Catheters. And we were all, very skeptical of his point. And then a couple of years later, there was a study in CHEST and 3,200 people in Worcester, in which they showed that putting in a Swan, or that the patients in a retrospective study really, that had Swan-Ganz catheters did worse than ones without them. And I think most of us thought of that as, well, yeah, the sicker patients got the Swan-Ganz catheters. And then it took until 2005, 20 years after Eugene Robin published that provocative basically opinion piece in Annals, till there was a randomized controlled trial in 65 UK ICUs that showed no difference in the effect, and so, no difference in the outcome of patients that whose care was, sort of determined by their Swan-Ganz catheter numbers. And so we sort of abandoned putting in Swan-Ganz catheters, and I think in the last years I was working in the ICU, most of the fellows really didn't know how to put them in because they just never saw them anymore. And so it moved to an era of ultrasound and non-invasive monitoring, which is, we're still in. This is still kind of in the physiology of ICUs. And there was a lot of political debate about the limited echo use by non-cardiologists. I remember having discussions with the folks that run the echo lab at Stanford. And ED physicians were interested in it because of trauma. And eventually this resulted in a national compromise between the American Heart Association and the cardiology societies in 2010 to let ED physicians do focus exams, and then a bunch of other kinds of limited exams, some of which were for trauma, some for sepsis, were kind of approved tacitly. And at Stanford, we hired a French cardiologist, a wonderful woman, Anne-Sophie Barreau, now lives in Toulouse, to teach us all the basics of ultrasound. And eventually she helped staff the Society of Critical Care Medicine's ultrasound courses and published a paper on how it should be used in critical care training curriculums. And a bunch of our trainees went out to other places and taught ultrasound, and many of our faculty taught it at the Society of Critical Care Medicine's annual meetings. So the next phase, I would say, was a shift to a more modern era when we're trying to learn more about the actual biology of injury and try to tailor our therapy to the biology of it rather than just the imaging picture of it or a few conventional markers like PO2 or maybe blood pressure. And we still use those things, of course, and they're dominant. But on the right is a cartoon from Michael Mathey. He actually had two of these editions in the New England Journal in which he shows some mediators of inflammation in the injured part of the alveolus on the right, interleukins and other things. And this, I think, is now the established new norm of what we need to be doing in critical care medicine is not just the conventional metrics, but figuring out what is actually happening. And it's extensive already. There's big biobases, biodatabases that are coming on board. I did a PubMed search last week on cytokines in ARDS. That was the search term. I got 5,895 results. Then I did cytokines and septic shock, and I got 6,000 results. So I think the general goal is to develop a panel of cytokines that can predict outcome and try to tailor our therapy more specifically to the individual's situation. Pretty good example of this from Stanford is on the next slide. And this was a paper in JCI Insight that Angela will recognize. I think Jenny Wilson on the team was the first author. And this was cytokine profiles in COVID and an investigation of whether they differed from cytokine profiles in other kinds of diseases. So the blue boxes in each of the interleukins is COVID, the red boxes is ARDS, the green boxes are sepsis, and you can see they're relatively similar. And the Stanford authors speculated that the cytokine modulating drugs that had been extensively studied really in ARDS without much effect probably wouldn't have much effect in COVID either. And then in a secondary analysis, they published something in Critical Care Medicine a few years later saying that high IL-18 levels are maybe a marker for mortality. So this is kind of where it's going, is trying to figure out for individual patients, rather than lumping things into syndromes, which has always been seemed somewhat offensive to believing that gastric aspiration injury in the lung is the same as sepsis in the lung. Probably not true, and we're doing it on old things like simple metrics and imaging. So another of our graduates, David Maslov, published 2 years ago in Nature Medicine, this paper that further refined what I was just talking about. So David said until like 1983 or 4, critical care was interested in just establishing the foundations of how to support people. And then maybe until like 2020, it focused on developing that and began to do definitions, like the sepsis definitions. There's 3 of them so far. There's a 4th that's pending. And prognostic scales, tried to get better at estimating what would, what we would be able to do if we were more precise. But I think where critical care is going is clearly trying to figure out the profile of individual illnesses and developing specific therapy. It just has to go there. So I'm going to talk about some other things that have happened in critical care. One of the things that happened was that neurocritical care became much more prominent. And this was very interesting because in the old days, it was just a diagnostic specialty, and then it began to become interventional. So the beginnings of neurocritical care, many people date to the polio epidemics in the 50s. This is a picture of kids in Los Angeles in iron lungs in the polio epidemics where, spinal anterior horn cells were killed by the virus. I think of it as mainly really emerging as a specialty that was more interventional when Sir Godfrey Hounsfield and a company called EMI released the first head CT scanner in 1972. And then you could really see what was happening. And we weren't just dealing with like pneumoencephalograms. And then much more invasive, starting in 1982, when there was the first paper on intraarterial thrombolysis. First symposium on it was in 1990. Now, of course, it's far down that road, and interventional neurocritical care we all accept as being something that is a really progressively important field. And it's a new field, as you can tell by all the people that are in our neurocritical care group. This is our group. And they have an extensive research portfolio, and they do a lot of clinical trials. Greg Albers is not a member of that group, but I think he led the clinical trials development in neurology. And they've actually contributed a lot of things that are not in the just normal areas that we think of ICU neurocritical care, like neurovascular, neurosurgical, trauma. But they've contributed things to critical care generally. So the first paper that I've instanced here, this is Karen Hirsch's first author paper in Circulation this year, 2024. Not a place you would normally think of neurocritical care, but it shows that they are allying with other groups. So this is a scientific statement from American Heart Association, the Neurocritical Care Society, about how you should manage people that are post-arrest. And it doesn't just involve neurological things. It involves how you should ventilate them, endocrine things, infectious prevention things. And it shows how broad-based they've become. And then they've also taught us a bunch of things that, again, brings humility to those of us in the field. So I'm just going to instance one. This is task-based EEG and functional MRI measurements of people that had what we used to call, somewhat pejoratively, persistent vegetative states. Now we call these unresponsive wakefulness syndromes. These are people that don't respond to commands and that exams don't show that they have any consciousness, but actually have covert consciousness. And if you do functional MRIs or you stimulate them with TMS, you can show that they're in there and they understand what you're saying. And 15 to 25% of people that have unresponsive wakefulness syndrome, actually, you can tell by functional tests are following what you're saying. And those people have better recovery. And so we used to withdraw support from these people all the time. And they've taught us that we were missing a subset that you shouldn't withdraw support from, and that some of whom do recover. And then just to carry this further, they published a paper in Neurocritical Care in 2022 that compared the prognostication of ICU patients by providers with and without neurocritical care training. And it turned that all of us that were general intensivists were just as good at predicting who would do really badly, but not as good about predicting people that would recover. So, this earns you a certain amount of cred. Of course, the surgical ICU has also been developed at Stanford. David Spain came in 2001. And currently it has a 3 fellowship program. It's a 1-year program. Sama Nassar runs it. And it has an option for another year in research, biodesign, or acute care surgery. And it has now 14 full-time faculty. So it's really, I would say, flowered over the years. So other things that happened over the years that I think are really important are that public demands for knowledge about what we were up to and what our outcomes were became very trenchant, very, very loud, and something that changed in some ways the ways that we practiced. So in 2001, there was the famous Crossing the Quality Chasm IOM report that claimed that we were killing 100,000 people by medical errors. And this led to the establishment of quality metrics in hospitals, but particularly in ICUs, that are publicly reported. And you can look up lots of things about our ICUs on the web and find out where we have, quote, quality defects. So examples of this would include like ventilator-associated pneumonia rates, central line-associated bloodstream infections, catheter-related UTIs. And then it got into specific mortality rates for disease states and procedures. And so there was a very high level of transparency and accountability that was ushered in, and it was particularly obvious in ICUs. So in my role for like a decade of being chief medical officer, I had to report to the board of directors of Stanford Healthcare how we were doing on all kinds of quality metrics. And of course, there's a lot of complaints from all of us about, is the metric a good metric? Does it really reflect what's going on? But it definitely put a searchlight on it. So on the left panel, I show, excuse me, every month, we started looking at every death in the hospital, the blue bars, and you can see the numbers like 54, 63, 50 of people that died in Stanford Hospital. And then the green bar is people that maybe we should have done something different. So every single death reported by month to the governing board. And then for individual things like central line associated bloodstream infections, we would identify areas where there was a lot of problems in it. And usually they were areas that you could imagine because of a lot of use of invasive lines. So in E29, which is, the old CVICU, we had a fair number of CLABSIs, and these are largely in ECMO patients because they're giant cannulas. And again, posting them every month to the governing board, and then developing an ECMO task force to try and get rid of them. And really what this, I think, did for us is we learned that with sufficient focus, you could find some things that are defects in our care, and that these systemic defects are more numerous than we think, and they actually can be fixed if you focus on them. So this is like an organizational thing. And then we would get into, various areas. This is ECMO patient outcomes. And again, we would look at what we predicted the mortality would be, what the actual mortality would be, what the case mix index is, elaborate report cards that I think convinced all of us that we should be paying more attention to our practice. And again, thinking that what we do in an orthodox fashion may not always be the best way to do it. And this became even more public when another Stanford person, Atul Gawande, who was a medical student here and then went to Harvard and then just moved on to USAID and various other things. He published the famous checklist manifesto. This is our first checklist in our ICUs. And what it did for us, I think, was that it taught us that even the smartest among us forget important tasks in our daily focus on pressing issues. So you may not pay enough attention to nutrition because you're worried that the map keeps falling. And so these things, I think, were in some ways actually helpful, although we all showed a lot of potential resistance to them in the early phases and thought that this was intervention by non-medical types. So corporations got into it as well. So big consortiums of employers that had many thousands of patients didn't like paying higher healthcare premiums. And so they started trying to figure out what could they do to improve outcomes and shorten length of stay. Most famous of these is Leapfrog. It was a consortium of employers that looked up in Medline a bunch of observational studies and determined that centers that had more intensive staffing, i.e. lots of people in the ICUs that were readily available, had better mortality and better length of stay in the hospital. In fact, high intensity physician staffing in ICUs, they claimed reduced the mortality by 39% and the length of stay by 29%. They published this in JAMA in 2002. And ever since, every year we have to fill in all of the data for Leapfrog to show that we're taking the measures that big corporate America believes improves quality. And, it probably does. And on the bottom is the 2024, our most recent Leapfrog, in which we achieved the standard that they define here. So this is also part of the public wanting more accountability in critical care. And partially as a response, partially as, I think, a way for us all to become somewhat better and be more standardized, there became protocols that were kind of elaborate checklists. And one of them over the last couple of decades has been the Surviving Sepsis campaign, where a number of experts in critical care got together and made up guidelines for how we should treat patients. This is the YouTube version of it right now. So it used to just be printed. but now you can watch it on YouTube. And the Society of Critical Care Medicine also promulgated some guidelines for COVID. The last one was in 2021, which is a little bit sad that it's, 3 years back, but this is the current one. They divided COVID into mild ARDS, severe ARDS, and then rescue or adjunctive therapy. This is obviously for patients in that have ARDS with COVID, not run-of-the-mill COVID. And I would say their recommendations are, very, very normalized. They do represent a consensus. They're not particularly innovative, but they are more or less up to date. And there's a lot of gray area. So if you look in the rescue and adjunctive therapy, neuromuscular blockade, prone ventilation, I think prone ventilation is obviously somewhat effective. Trials of nitric oxide, and then consider VV ECMO or referral to ECMO. But of course, that's not like strict inclusion criteria. It's more generalized than that. But it did, I think these kinds of things do introduce, particularly to community ICUs, what the current normal standard of care is for treatments in ICUs. Now, there are a lot of challenges in critical care medicine and that are somewhat unique to the field. They're not entirely unique, but they are much more particular to critical care. And the first one is access. So access to critical care in the United States is not uniform. The checkerboard on the left shows intensive care bed availability in hospital service areas. And it shows that it's, in certain areas, it's much easier to get to an ICU bed. This is partially an issue of how good is critical care transport. And are you too remote from somebody that can put a catheter in your head to give you thrombolysis of your stroke? And the answer, of course, is many areas are. And on the right is an even more troubling thing. And this is intensive care bed availability by median household income. So this is like the rest of medicine in that higher socioeconomic groups do much better, live longer. College grads actually live 7 years longer in the United States than people that are not college grads, and their income's higher and they have more availability to services that extend their life. So on the right-hand panel, the light green bar shows the lack of access to patients whose household income is below $35,000. And on the extreme right is household incomes greater than $90,000. And you can see that they have almost universal access. This is the 0 bed line for no access. It's very small, but it's very large in household incomes that have less money. And you can plot this out and determine that each $10,000 increment in median household income is associated with a 16% increase in ICU bed availability. So this is not a simple problem to solve, but it is a problem. And it's even more a problem worldwide. So on the right-hand panel is a picture of the Democratic Republic of the Congo, DRC. And on the bottom is a picture I took in Rwanda, in Butaro, where there's a new medical school that struggles to have access to resources. So there's no ICU there. The only ventilators are in the OR. Only very limited kinds of surgery can be done. It's a medical school. And you can't get a culture. So these are problems. Anna Crawford co-authored an opinion piece in Critical Care Medicine last year called Global Critical Care or Call to Action about this problem. And it's interesting that in most low-income countries, government healthcare spending is very low because they've written it off. They don't prioritize healthcare. And there are estimates about how many people might benefit from critical care if it were accessible, and they're large, like 11 million deaths from septic shock, 2.5 from pneumonia, which is really pretty simply treated in most instances, or 18 million from cardiovascular disease. So I'm not sure what the solution to this is. During the Ebola epidemic, there was universal concern about how to make it better. And the UN and Rob Fowler were there trying to stamp it out. But when COVID came along, the rich countries got all the good vaccines. The poor countries got none, or they got an inferior Chinese vaccine. And so it wasn't as if everybody just stood up and said, let's make things available. So it's a checkered history. Why is all that a problem? It's obviously because of critical care costs. During the 80s and 90s, there were massive bed closures in the United States. And by the mid-90s, the number of hospital beds had somewhat stabilized, but the critical care bed use continued to rise. In the year 2000, there were 87,000 critical care beds, and they cost about 0.5% of the GDP. Then by 2005, there was a big increase in prices for critical care, and the cost rose 44% over 5 years. And then more currently, the ICU bed count's about 112,000. So it's gone up about 50% from the year 2000, and the costs are about 1% of the GDP. So this is part of the barrier of access, and the federal government has not really stood up to it. So this is reimbursement for hospital care generally. And in the left panel, this is inflation in the last year when there was a lot of inflation in hospital costs. And this is how much reimbursement is increased the hospitals for that inflation from the federal government. And then if you look over several years, cumulative Medicaid and Medicare underpayments, between 2013 and 2017, it was short $375 billion. But 2018 to 2022 was short $522 billion. So of course, private insurance makes up the gap for most hospitals. And that's why all our premiums are rising. But again, this is a big problem. And then we have the silver tsunami. And this is also an important issue in critical care units. Thank you, Angela. So over 80 age cohort is the fastest growing cohort in the United States. And right now, 55% of all ICU beds are occupied by people over the age of 65. And so, not sure why that's coming up. But the spending over time is a lot more than just the silver tsunami demographics. It's the rising cost of healthcare that far exceeds even the silver tsunami. And so this is a big issue. And so this naturally goes into, well, how do we select patients who might benefit from critical care? And in the past, we've mainly used these 4 validated scoring systems: Apache 4, SAPS 3, NPM 3, SOFA. These are reasonably well discriminative and calibrated prognostic scoring systems. But of course, they're accurate and apply only across groups, not for individuals. And they only match the kinds of patients in their databases, which in the current world seem like small databases. And the age in ICU, which intuitively you would think would be good predictors of who's going to do well, actually aren't that good as single discriminators. I looked at this like a decade ago, and I just took the 25 longest ICU patients and tried to figure out if they all died. And the answer was only about 25 to 35% of them died. So people are in the ICU for 100 days that we're continuing support on frequently do better or do well. I mean, they have an excess mortality compared to general ICU mortality. And of course, it's because we're individualizing the therapy and we're thinking this person doesn't necessarily have to die, but most of the time they don't. And in JAMA in 2019, there was a big study of 134,000 people in ICUs in France, all patients in France with national insurance. And they looked at something very important, which was the survival of older patients post-ICU. Excuse me. And what they found was compared to 18 to 34-year-olds who tend not to die after they were discharged from the hospital, as you get older and older, you have an odds ratio of up to like 20 for dying shortly after discharge. And if your median survival for those greater than 80 was 24 months if you're 80 between 84, only 10 months if you're between 85 and 90. And if you're 90 and getting an ICU in France, you're very likely to die in the next 4 months. So, but again, this doesn't allow us to really triage patients because that's not how we care for people. We care for people to individualize it, and we have this notion that everybody gets the best chance possible. Now, I think our prognostic scales are going to get better because of machine learning. So this is a prediction algorithm that uses machine learning, and this is conventional SOFA and Apache, and this is a machine learning prediction algorithm. The area under the curve, which is what we usually use to estimate the accuracy of it, is much better in the machine learning one. That's for mortality. Length of stay is the same. Machine learning does much better than our usual prognostic scales. And so this is getting to be the new standard. There's a paper in Journal of Intensive Care Medicine this year that looked at 400 studies using prognostic scales. Only 16 of them used AI methods, but all of the 16 showed much better prediction than our conventional scales. So in case you think this isn't spreading rapidly, right now you can enroll in a Coursera course from Stanford. There are 36,000 other people already enrolled in it. It's offered in 22 languages because I'm sure it's translated by machine learning algorithms. And so, man, this is out there and it's great. It is really great that we can deal with bigger levels of databases and analyze them more quickly. So the last thing I'm going to talk about is the COVID challenge, which is fresh in everyone's mind. In the beginning, the inadequate critical care staffing, not enough intensivists, not enough nurses, lack of ICU beds resulted in worse outcomes. We had a conference call with many of our ex-trainees who are in other academic medical centers, and we learned what was happening in the East Coast in real time, and they were like ICUs in regular wards run by psychiatry interns. And it was not good. And a lot of people, I think, suffered a worse outcome. But, eventually we got around to learning that proning was really valuable, that not intubating people, that you could get away with non-invasive ventilation was great, that some things in specific subsets like steroids were helpful. The therapeutic agents were more controversial, particularly remdesivir, but specific monoclonal antibodies helped. Paxlovid in minor cases helped. And one of the most important things we learned was that protective measures prevented staph infection, and that the panic that everyone felt in the beginning, all the intensivists and nurses are going to get COVID and end up on ventilators, didn't turn out to be true. The people that got sick were the people in the hospital that were living in aggregate living quarters, where the food staff, the people that transport our patients, and they bring it into the hospital because they get infected at home, but very, very few people got infected here. And then one of the things that illustrates really well the problem that we all have in ICUs is when to use highly invasive therapies as rescue therapy. And because we have the belief that offering care is what we do, if somebody is in reasonable health and has a desperate illness, and we've used everything we can, we pile on and do what we think might help. It's very difficult to do trials in those kinds of patients when we're desperate to try and help. So ECMO in COVID was valuable, I think, for many patients. The question is which patients? And I think because of our reticence to deny care to anyone that might possibly benefit from it, we try and do what we can. So ECMO is an interesting technology, and the big trial, the New England Journal, that was a famous trial, the Eolia trial, didn't show in ARDS that it overall improved outcome. But there were subsets that you could imagine that it really did work in. And I think that's been our experience. And then when COVID came along and a lot of people got put on ECMO, this shows, the graph shows what happened in Europe. So the light colored ones are the initial wave in the United Kingdom, in France, Spain, and Germany, and Europe, and Israel. So this is the mortality rate for patients put on ECMO with COVID, and it's pretty good. And then in a later wave, it was higher in all of those countries, and we're not really sure why. So the Society for ECMO also produced some guidelines in 2021, but really we didn't have enough data to like refine it better. And again, I think we fall back on offering care is what we do, and if we think someone might benefit from it, then we do it. There is no randomized trial on COVID for ECMO for that reason. And here are 3 trials that involved like 15,000 patients, and they show various survival. The first one showed successive mortality rates that were higher, as I showed in the first slide. There's a European multi-center COVID ICU trial in 4,000 patients, and it showed some improved survival compared to conventional therapy at 7 days, but 90 days it was the same. And then the critical care consortium trial had 7,000 patients in it. 844 of them had ECMO, and their mortality was lower by 7.1%. These aren't randomized controlled trials, so I don't really know what to make of it. But I do think it illustrates this point that when we have something and someone is desperately ill, what critical care physicians tend to do is offer it. And yeah, I don't blame them for that. I think it's probably the appropriate thing to do, but it doesn't push ahead our understanding particularly. So I'm going to offer a few final reflections. 50 years, Stanford critical care has obviously broadened. It's become more broad-based and data-based. It's been increasingly influential in the larger critical care community, partially through our trainees. And again, the lesson is our legacy resides in our trainees, probably more than it resides in our papers. And that's something we all need to consider. And I think Mike Rosenthal believed that from the beginning. And like other intensivists, we've been both humbled by our mistakes. I showed a couple of them. They're not unique to critical care medicine. Like 30,000 people got bone marrow transplants for breast cancer and it didn't work. But, we should be very circumspect about orthodox methods. And then I think that machine learning and AI is likely to really help us in many areas, like early identification of significant biomarkers, genetic analysis. The genome is obviously now much more readable. Prognostic scoring systems are going to get better. Basically, everything that is database is going to get better. But as practitioners, in the end, the same old things apply, like patients first, trainees too, because they're an important part of our legacy, and spread our influence, science when we can do it. These are still foundational. And I think as a community, we all owe a debt of gratitude to each other for the mutual support that we've had over the years, and allows us to produce new intensivists that carry it forward. And as I think back over 40 years I've been involved in it, I would say my first feeling is there are things I could have done better, and some things I out and out regret. But I think all doctors that are trying to become better should have those sentiments. And when I get over that, I think about the astonishing opportunities Stanford Medicine offered me and is offering everybody in our communities and all the disciplines. And the gift it gives all of us about being able to do something consequential with our lives. So I'll leave it there. I have just a few minutes for a few questions.
Thank you, Norm. Thank you for giving us that overview and highlighting some of those Stanford specific points. I do have some questions from online, but any live questions? We're going to alternate between online and live.
Norm, first, thank you for that tour through 50 years of critical care at Stanford. Want to really thank you for all you've contributed to Stanford and to critical care, specifically at Stanford as well. You began emphasizing that Mike created multidisciplinary critical care at Stanford, and Stanford has in many ways been a national leader in multidisciplinary critical care. You were an incredible advocate for it. At the same time, you mentioned the increasing development of specialized ICUs that with them have often very domain-specific providers. What are your thoughts as to where multidisciplinary critical care is going in the future, and any recommendations you might have on how we might alter that direction?
Yeah, so this has been an area of a lot of debate in critical care medicine nationwide. The biggest paper that has ever been published on it, on outcome from domain-specific ICUs versus multidisciplinary ICUs, involving over 100,000 patients, was published in the American Journal of Respiratory and Critical Care Medicine. And what it showed was not surprising. It was that in specialty units, the care for that specialty was better and had better outcomes from that specific problem, but that the care in areas that were not touched by the domain was worse, and it was a wash. So I think that's part of why multidisciplinary ICUs have not prevailed, and that and I believe that domain-specific ones have become more prominent for two reasons. The first is, unfortunately, financial, because I think that departments need the revenue from their patients, and they don't want to surrender it to a different group. The second is the knowledge base in domain-specific areas is clearly superior about the disease they're taking care of, and it's very obvious to people in that specialty. And so I think what I tried to advocate near the end was be more inclusive so that you get more points of view and knowledge bases that you might not otherwise get, but acknowledge that specialty care is superior in some ways. And so what I would advocate is, like in the surgical ICU, there's Javier, there's Paul Mahavir. So they have like an internist, they have an anesthesiologist. I think that's, and the other 14 faculty are all surgeons. So having some outside opinions that are knowledgeable about fields that are alien to you are is really valuable. And, in a surgical ICU, there's plenty of pneumonia and renal failure, and those don't appear to be surgical. And in medical ICUs, there's plenty of people that get bowel infarcts or, things that require surgery. So we really need to share our knowledge, not be so proprietary. It's hard to do. And I think nationwide, it's moving towards more domain-specific areas. I mentioned critical care in a little more detail because I think that's an area where really it's pretty darn clear that general intensivists can't provide all the care that's needed there. And so that, it's a mixed bag. And that's my thoughts on it.
Norm, thank you very much. I enjoyed it, hearing the 50-year history as well. And I too believe that Mike Rosenthal started something that at the time he probably didn't realize what he was creating. It has been massively successful across not only here, but around the world, populated every place. My question is related to the Stanford ICU as it is today. And perhaps, I'm not sure how close you are, but I would imagine that it's still pretty full most of the time.
Well, as you know, the hospital census far exceeds the capacity. And there is some variability in ICU census, but it's, we increased the bed count tremendously during COVID, so that provided a lot more. It's about 16% of the hospital beds right now.
What should it be? What could it be? How are we deciding who gets in those beds? Who's making that decision? What criteria are being used? And how do you see that evolving at Stanford over the next 5 to 10 years?
Well, I think this falls to what I was talking about before. Is it's really hard to deny care. And if someone believes that the patient would be better in the ICU, in general, they get in. Sometimes with some discussion about whether it's really appropriate, but okay. And I would say a lot of the issue in ICU beds, there's people that are not critically ill that are just there for monitoring after some event. And those are the ones that benefit the least because it's very rare for them to have an event. But as to how many beds should be in ICUs in a hospital, again, that's highly variable. Most hospitals in the United States now are between 10 and 15%. Academic centers tend to have a few more, but I think the COVID epidemic had a big influence on it. I think 15% or so is probably right. So I think the number of beds is about right.
There's a question online from Anna Crawford.
Oh,
And
okay.
she's thanking you. Thank you for pointing out access challenges within the US. It is a challenge in global health to convince folks that global includes local. If you were to advise the institution of Stanford Healthcare, how would you frame the argument that we need to engage in greater community outreach to our rural communities to build critical care services?
Yeah, of course, this is also contaminated by money. Because rural communities in general have lower socioeconomic classes in them. They tend to be not have as much private insurance. And so hospitals everywhere are reticent to open their arms fully to, for example, Medicaid patients because it will bankrupt them. And so Stanford Hospital has a policy of course, taking Medicaid, but we don't reach out and try and pull it in because we're concerned about financial viability. But it's obviously a flawed method. And we're surrounded by healthcare centers that refuse more care to Medicaid. I was talking to a domestic worker last night who needs to be seen. And she can't be seen at El Camino because her insurance isn't good enough. They won't see her. Or the Palo Alto Clinic has a very, very limited amount of Medicaid. And if you go there, you may be sent to the Stanford ED. So this is a philosophic issue that revolves around the operating margin of hospitals. And Stanford Hospital has by hospital status, has conventionally had a pretty good operating margin, like in the range of 5 or 6%. Now, if you were a corporation, you had a 5% operating margin, you'd think you were miserable and you'd fire the CEO. For hospitals, that's pretty good. The Mass General usually is around 0 to 2%. And UCSF struggles in the same way. Their operating margin is quite small, and they want to take as many Medicaid patients and uninsured patients as possible as a public service and a public university, but they're constrained as well by their operating margin. So, the pie in the sky answer is universal health care. And we're spending 18% of the GDP on healthcare. We have some of the worst outcomes of all developed countries, in my opinion, actually in the AMA's opinion, which is somewhat surprising for those of us that used to think of it as a conservative organization. They want a single payer. And I think that's the real solution, and stopgap measures are valuable, but only to a limited degree. So we have some outreach in East Palo Alto. We should have more, in my opinion, but those are the constraints. And of course, Anna's very aware of this.
One other question from online about if you can refer to or mention some of the clinical and economic impacts of the Society of Critical Care Medicine ICU Liberation Campaign to widely disseminate the use of the ABCDEF bundle across all ICUs, and maybe even a broadened context on that question about the impact of some of these national, collaboratives that extend beyond the ICU.
Yeah, well, there's several things wrapped up in that question, but one of them is, what happens in post-ICU care and what are the long-term effects of people in ICUs and how are they supported afterwards? And this has been an area, I think, across the board in critical care where there's not been enough interest. There was a lot of interest 7 or 8, maybe 10 years ago in delirium states resulting in cognitive defects and how we manage delirium in ICUs. It's a very, very significant issue. And the idea of having protocols for anything, including liberation from ICUs, I think is really valuable and very, again, difficult to implement because not everyone reads the guidelines and adheres to them. And a good example of that was, a simple example is when lung protective ventilation came in, that clearly improved survivorship, was simple technically, and just required changing the ventilator settings. I thought it would be universally adopted. And then there was a study at the University of Washington that looked at all the community hospitals and showed that like less than half of them had adopted the protocols, even though it was super simple, didn't require any new equipment, improved mortality. So I think that, that's a huge problem for any guideline. But I do think we haven't paid enough attention to what happens to patients post-discharge. And we really need to have like post-discharge clinics for ICU patients, see how they're doing and learn what we've been doing that's not right. Because as I showed, we have habits. Sometimes when the habits are studied, they just show not to work. And they're orthodox, Any other
questions? All right, from Rosenthal himself.
Fantastic, Norm. Thank you so much. And thank you for what you've done. I had it for 22, you had it for 24. You always said you would not exceed me, but you did. So Javi, 25 for you, right? When one of there's so many things that came up in your discussion, but I want to just dwell just a second on the domain-specific ICUs.
Yeah.
For obvious reasons, just looking at my own history, I guess I'm not a strong proponent, and it always bothered me. And the political considerations, the economic considerations always bugged the hell out of me as the driving force. But the one place that I wonder about as to why results may start looking better is nursing care.
Mm.
And I cannot help but wonder if the specifics of nursing training and what they do in domain-specific ICUs might not be a major factor.
Yeah, I think that's absolutely true. And I'm sure it's true in the OR as well that, people like to have teams in the OR for the specific kind of surgery that's occurring. And it's very true in the ICUs. There's no question about it. It's not just knowledge-based and domain-specific ICUs that's valuable. And again, the issue, of course, is when you fracture ICUs into smaller and smaller groups that have differing census, it's hard to staff them right because, there's a lot of variability when it gets smaller and smaller in units. And so it's really difficult to have the nursing be specialty specific. But there is no question that the nursing is a giant feature in ICU care. And the relationship between the physician staff and the nursing staff is also giant. And I know you remember well a paper in the Annals of Internal Medicine that called out Stanford for having, this is many years ago, maybe 30 years ago, called out Stanford for having quite a good relationship between the physicians and the nursing staff, and for that reason had improved outcomes compared to other ICUs. So it's been studied, it's true, it's obvious, and you can see it in other domains besides ICUs, but it's a really good point. I think one of the things that we've had at Stanford is, weekly reviews of all the patients in the ICUs with the nursing staff, with biomedical ethics, with palliative care, and having like the group consensus is fantastically important. And having the nurses and all the caregivers involved in it, not feeling marginalized, is major.
Still have that conference, although now we do it over Zoom. So we used to come together in a room, and I remember there was always a little play with crackers and cheese. And it was 2:00 and it was the perfect time for crackers and cheese. Anyway, Norm, we can keep you here for another hour for more questions, but maybe this might be a good time to end it since we have to start the ICUs. Again, thank you. I know you're going to be spending the morning with